Well, and so that whole idea of copays and copayments and incentivizing does kind of, it's an interesting conversation in of itself. I know that maybe that Taylor mentions it in Nudge, but like the whole idea of what insurance is, or the cost sharing that patients are going to have given a specific service, will incentivize things. And that in and of itself changes the demand, which changes the everything, right? Like one little ripple in this pond has huge consequences down the line.
Yeah, well, I mean, the whole theory behind cost sharing is this idea of moral hazard. So the idea that you are willing to consume more healthcare because you don't sort of incur the full cost, price, right? And that always makes economists nervous. And so they, they assume everybody is risk averse, and that you'd rather pay for insurance than sort of run the risk of having to pay, for your healthcare. And so when the all policy sort of goes with that, that then can drive up prices in and of itself, because patients still don't see it. And so, raising those prices it's not felt by patients. So you're right, it's complicated, and just applying a copay doesn't necessarily make sense, especially for, services that no one would ever consciously, intentionally overconsume, like major cardiac surgery or things like that, right? You're not preventing them from inappropriately spending insurance companies' money for those types of things. And studies have even shown that the opposite is true, that people will avoid preventive care if they have to pay for it, which is the exact opposite of what we want to have happen. So from an economist standpoint, there's this idea of efficiency, like what's the most efficient way to spend these dollars? And the way that we're doing it right now often ends in inefficient situations, for sure.
Yeah. I think in your book, you mentioned that the asymmetric information leads to that kind of inefficient spend or utilization of healthcare, right?
Yeah, I mean, again, when consumers don't really have full information, they have to rely on their clinician and the advice that they're given, and then they bring to it certain opinions about whether, for example, vaccines are safe, or whether they need medication to treat a certain thing, and they're going to ask for it. I want antibiotics or whatever it is. So not having the full information about, clinical information, pricing information, future outcomes information, it's impossible to make the most rational, best choice a lot of times. And so it causes all sorts of inefficiencies in terms of how much is consumed, how it's paid for, who pays for it, things like that.
Yeah. Well, and it puts the talk about incentives and like potential fraud and stuff like that. It puts the clinician in a very powerful place, right? Like if we know service A is reimbursed higher than service B, the patient doesn't know anything about how service A or B is going to turn out. Why aren't we just going to encourage that one that pays us a little more, right?
Right. And I mean, and it adds the potential for fraud and abuse, but also for perceived fraud and abuse, right? Because it's not always, intentional. And, consumers, a lot of times after they even receive their service, it's hard for them to sort of determine, did that help, right? Maybe they feel a little bit better, but is it due to that therapy, or is it due to something else? How do they know? So, that too in economics complicates things, because if you buy a widget and it works, that it has the value that you paid for. In healthcare, sometimes you can get a treatment and not know how much it helped. And so it makes it harder to assess, was it worth it? Should have I done that? What advice am I going to give to someone else? And so it continues to complicate this idea of when is it worth it, or what is the value of a particular product or device or service.
Well, and even the variability of just people and their reactions to those, the randomized controlled trials, which are, the gold level for evidence, are still based off like the perfect population in the perfect setting with only one variable, right?
Right. And so the other side of that is, quality improvement initiatives that are put into real world situations, but then those are confounded by whatever else is going on, right? And changes in policy, or another initiative going on, or changes in staffing, and anywhere that delivers care, a hospital, clinic, they have a complex sort of makeup of individuals who all have their own levels of experience, and all their own opinions. And so there's no two that are the same. So in terms of variability, it's through the roof. And so that makes it hard too to assess. How do we know that the value we see here today, whether it's a clinical trial or it's an initiative, is going to translate to another setting, to another place, to another clinical indication? We may not. And so we have to think about that when we're trying to assess, well, what is the value, or what might the value be? Because a lot of times too, we just try and come up with a single number. This is the value. When in any other area of measurement or probability, we have some notion of sort of uncertainty or confidence intervals, and we just seem to sort of forget that in the value world.
Yeah.